questions about last time? Any questions about last time? Increased intracranial pressure. We talked about how important it is, right?
Are we going to have to, we have a question maybe where we have to identify some of these spots that are
It would be difficult for me to write a question and describe the patient and assign them a hospital. I'll say that. I'm sorry to confuse you. It's not a huge deal, but what you need to know is how to assess the dermatomes. And you assess the patient can sense pain, you assess the patient can touch, they can sense vibration, change in position, and temperature. Those are the different assessments that we use to assess dermatomes. You will not be expected to know that, the T11 dermatome is just going to be ambulances. That's too much. But do realize that if a patient, and we'll talk about spinal cord injuries, but if a patient had a T2 spinal cord injury, they will have some impairment from T2 down. So, and you will have to know kind of in general maybe where it is, but don't learn specifics about these things. Cervical, thoracic, lumbar, I think we should be able to do that. Cervical, basically upper chest is in the head, thoracic is the thorax, and then the L spine is the lower extremities. Okay.
So, when you're talking about the CPP and the bare minimum being 60, would essentially the steps that you're wanting to take to be able to assure that it is 60 be to reduce intracranial pressure? That's the issue, or increase the natural? That's the issue.
Right. So the thing is, number one, you want to make sure that the ICP is no greater than 20, sustained for sure. But if the blood pressure is, with the map of 60, you would have to have an ICP of what? 0 to perfuse the blood. So most of us probably have an ICP now, 1, 2, sitting here. So our map needs to be at least, 60. So, but to do that, the thing that we would change the most is to try to get the ICP down because the ICP problem and maintain a good perfusing blood pressure. Just a combination of those. But always make sure the ICP is 60. But a normal person that doesn't have a problem with this, we're good. Most of our maps are 70 to 80, 90. So, we're good. Making sure ICP is down is the problem. Any more questions? So we talked about increased intracranial pressure last time, so let's talk about more specific things that can cause increased intracranial pressure today. A very common thing that you will see in critical care, in acute care, critical care, is traumatic brain injuries. Memphis has no shortage of patients with traumatic brain injuries. You will see them very frequently. And loss of consciousness, I put that there because this person that has had a traumatic head injury loses consciousness, they should be monitored very closely because they have increased risk of having a brain bleeding. Okay, so just keep that in mind. But a traumatic brain injury, the patho, for some reason the head is struck with something, or the head shakes and the brain bounces around inside the skull. The brain has received, for some reason, some sort of trauma. And because of that, what happens? If there's injury to somewhere in the body, you're going to have an inflammatory response, right? So swelling, and all of that. So therefore, that swelling causes cerebral edema, which can lead to increased ICP and cerebral bypass, right? So we talked about that last time. There's more patho. These are types of traumatic brain injuries. Acceleration means that something strikes the head, baseball bat to the head. Okay. Acceleration, deceleration, the head strikes something. It could be an MVA, patient is under strain, and the head hits the windshield. But acceleration, deceleration. Coup contre coup is maybe it was an MVA and the patient had their seatbelt on, but their head was violently swung forward and slammed back against the head of the seat, and there was no really damage to the head itself, but that brain sloshed around inside the head, and by striking inside the skull, it caused trauma. Does that make sense?
So the acceleration and deceleration, so they are not like backward, so you accelerate and decelerate.
Right, but the head actually strikes.
Okay, but you strike and then you don't push it back.
Acceleration, deceleration.
So what's the difference between the control and the control?
The accelerator is the head is actually striking an object, and that by striking that object is what is causing the trauma. And a contra-coup injury, the trauma is caused by the brain sloshing or hitting the skull, and the brain hitting the inside of the skull and causing trauma.
You're not hitting something.
You're not hitting something necessarily. You might hit something, but you're not back in the seat. You know, the injury comes from the brain moving in the skull. Rotational injury is similar to contra-coup, but this is where the brain would twist inside. And then you can have an open or penetrating head trauma, and something has gone into the skull, a knife, a nail, a bullet, or something like that. Right?
Give an example for rotation. How to twist it.
If maybe if a child is shaken or something like that, that may cause rotational injury. But that's probably the least common. But you know, they could happen, and it's probably not good because it would damage the brain stem. All right. Hematoma, which basically is a bleed. Right. So this is a head bleed. And they're named based on where the bleeding is happening. So for some reason, we've had a head injury, a brain injury, and because of that, we have bleeding. Epidural bleed is bleeding in the epidural space. That's how it is. And just remember where the epidural space is out here, right? Between the dura mater, which is here, and the skull. So this is usually arterial. So there are lots of arteries in this dura space. So if it's damaged, the artery, remember that if you have arterial bleeding, it bleeds much faster than the venous bleeding. So therefore, this head injury can develop very quickly. This hematoma can develop very quickly. A subdural hematoma is, you see the dura, the little blue space here. The subdural hematoma is below the dura. So it's below, between the dura and the actual brain tissue itself, or the arachnoid layer. So this bleeding is surrounding the brain. And it is usually a venous bleed, so therefore this would develop over a longer period of time than an arterial. This long word here is intraparenchymal. It means the brain tissue itself. Intracerebral, it's easier to say. So intraparenchymal bleed is where the brain tissue itself is bleeding. And it might be deeper within the head. It's important to know where the bleeding is happening. Specifically, if it's venous or arterial, it's going to be fast or slow. Alright. We can also have a subarachnoid hemorrhage. This is actually bleeding below the arachnoid space. And often this subarachnoid hemorrhage happens because of a hemorrhagic stroke, which we'll talk more about. Subarachnoid hemorrhage is often a hemorrhagic stroke. It often bleeds into the ventricles, and therefore you would see blood in the CSF. That's a big sign of the subarachnoid hemorrhage. There's blood in the CSF. Nice, normal, clear CSF over here. This is blood tinged CSF. Hydrocephalus might occur because you're having extra volume inside. And that's what hydrocephalus is. There's volume inside. Ventricles usually it's too much CSF, but anything in there is going to cause swollen ventricles. Right? Another type of head injury is a diffuse axonal injury. This can be a really big deal. So this is where there's diffuse tearing and disruption of the brain matter itself. The neurons are disturbed. This can be a very severe situation, or maybe it's not extremely severe. It depends on the extent of the damage to the brain tissue. So, so when you see the word diffuse, just remember that means all over, right? So a mild form of a DAI might be just coma for less than a day. But a severe DAI would affect the person probably for the rest of their life. They would never return. So these are basically just some neurological manifestations. And these behavioral changes you would see in a more mild to moderate DAI, because the person that has had a severe DAI is probably not even going to away. What's that? I can't hear you speak up. I'll get there. So the priority when treating a traumatic brain injury or a head bleed is to control the bleeding if possible, right? So that's the priority. Fix the underlying cause. The bleeding should be controlled. And the person who is having neurological deficits related to a head bleed, probably they will want to do surgery, so maybe a craniotomy or cranium, right? Where they go in, and what they say they evacuate, pull out their bleeding, that pocket of bleeding, the hematoma. Your increased intracranial pressure care. We talked about blood pressure, and if the patient maybe, mentioned our grandparents who are just thinking the most fragile people ever. A lot of them are on warfarin for their AFib, or they have fatigue, and they fit on the back and they make it dead. Well, they're going to bleed a lot worse, right? So make sure that we're correcting any coagulopathies that our patients have. Maybe it's medication release or whatever. Maybe it's pathological. So close assessment for that. So a good thing that we would do is make sure that we get that vitamin K in quickly, so our patient has a subarachnoid hemorrhage or something, right? You don't fail in your head. This says head of bed low and less increased ICP. In the lowering the head of the bed as much as possible while still maintaining a normal ICP helps with the perfusion of the brain tissue. Okay? That's why we do it. But if the patient has increased ICP, lowering the head is going to make the ICP worse and further prevent perfusion to the brain. So keep your head as low as possible, if they have a head injury, while still maintaining a normal ICP or a normal neurological status. We don't always actively monitor our ICP. We look at our clinical assessment skills to see if we have any changes. Right? Often the eyes are affected because of the trauma. What else? And this is diabetes insipidus, SIADH, and salt wasting. Those are complications of head traumas and head bleeding. So continuous assessment. And our easiest assessment to assess for these things is urinary output. I made you this chart. I think that you've been introduced to diabetes insipidus and SIADH. But here is this chart, and I thought that it was good, and it just shows you what's high and what's low. And then, salt wasting is probably new to you, but it's similar to DI, but you have a low serum sodium instead of a high serum sodium, right? It's salt wasting. You see, that's the only difference between DI and salt wasting. It's just a sodium. What's those two? Specific gravity. Other complications are related to the treatment of these patients, so pneumonia, anaphylactic system or ventilator, and UTI because they're probably going to have to follow, right, and stress ulcers from being in the hospital. Convalescence is a part of the healing period. The period of convalescence is a period of up to 6 months after this injury. The person still has neurological deficits. illnesses. Sometimes people are permanently affected, but often, or sometimes patients nearly fully recover from these things. But there is a period in which the acute phase is over, but they still have some lingering neurological deficits, and that's the period of convalescence. All right? I know that was brief, but skull fractures. This is not extremely complex, but realize that you can have open or closed skull fractures, and you remember that if you have a fracture that's open, what does that mean? The skin is broken, right? And closed fractures, the skin is not broken. A skull fracture can very easily lead to a traumatic brain injury or a brain bleeding.
Doesn't opening the skull is cracked and the air can get in, or no, just the skin on top of your head?
That the skin is broken in the fracture. If it's a fracture, means the bone is broken. Does that make sense? Yeah.
Going back to the last slide, when we talk about the sodium and the fluid replacement, that's going to make we're going to have to decide on what kind of, or I guess the order will be written, but then we're thinking, well, is that hypertonic or normal saline? So when I think about that, I'm going to have to think about what kind of fluid I'm going to replace with because of the
No, because that's not a nursing decision, right?
Okay.
Generally, it would be isotonic solutions that we use to rehydrate patients. But just know that, and because in SIEDH, it's opposite. We give fluid, we restrict fluids, but in solid waste and DI, we need to replace fluid because of fluids.
But I don't have to worry about whether it's hypertonic or
You have to decide that because nurses do not make those decisions. Sometimes we have to anticipate the order, but on a test, I'm not going to make a decision between things. Some things are within appropriate to know that, but so because if I wanted you to know that, I would have put on here only normal saline, only. This is just a review of types of some types of fractures that you're probably used to. Linear is just a crack. Comminuted means that there's lots of broken pieces, and depressed means that it's probably comminuted, but also it's depressed. It's pushed into the skull. So compound fracture is usually open, and a depressed fracture is probably open too. A basilar skull fracture is more on the back lower part of the head, and there are some signs of this that are classic, like raccoon eyes and draining CSF from the ears. So, there I further define these for you. The most important thing to know is basically this slide, for you to know that where the fracture is on the skull will let you know what types of manifestations you will have. Some of them are the same, like you have a parietal and a temporal, and you may, with both of those, have CSF from the ears. Also, the basilar fracture. So, I'm going to make you differentiate between ones that are different. What stands out? What seems different than the others? Does that make sense? Like raccoon's eyes, right? I'm not going to read that to you. Is that okay? All right. You want me to read it?
No, but why do they get raccoon eyes?
It's bruising. It's bruising around the eyes, and it's just what the damage is. It causes trauma behind the eyes and around it, not the eye itself. So because we might have an open skull fracture, and the brain, of course, is there a place, and the patient is at risk for meningitis, which of course is infection of the meninges, or an actual infection of the brain tissue can happen too. Because this can cause brain bleed, increased ICP is an issue, and those treatments that we talked about in brain injury, neuro assessments. And this patient may have increased risk of vomiting because remember increased ICP. So I just wanted to review the medications, Phenergan and so forth. So be sure that you know how those medications work. And then the long-term side effects are those extrapyramidal. So that's important. Zofran is sometimes a better choice over Phenergan because Phenergan causes sinus depression. Because if you're a patient, you want to be able to do a good assessment, so you don't want to give them a lot of neurodepressant. Okay. Just remember how those medications work. Like Zofran works on what the chemo receptor zones, all those things. Probably popular cases. All right. Give your patient the least amount of analgesia possible to control their pain, because again, we want to be able to do a good ongoing neurological assessment. We want to see if they're deteriorating, if their injury is getting worse, and if they are declining. So, give the mildest type of medication possible. This is not to say that morphine and Dilaudid are contraindicated. It's to say that we should use the lowest dose effective. So if the patient has a headache, you don't want to get 3 milligrams of Dilaudid. Give them some collagen first and see if that can relieve your headache. All right? We talked about craning. Burr holes basically are just holes that are drilled into the skull so that fluid can drain out. This is not done very often. Usually it's just a big craniotomy, craniectomy. These were some good pictures. So this is like comminuted depressed fracture. You see that? This is raccoonized. This is battle sign. This is more raccoonized here. And this is blood, probably bloody CSF from the ear.
Which one was the battle sign?
Behind the ear. What sign is that? Battle sign. Yeah. It's also recognized. It's not as severe. Looks like you probably have some fractured nose too. It's probably just a vertigo idea. Looks like maybe you fell into some pavement. It looks like he had glasses on. He got to fill his nose. Yeah. This here is called the halo sign, and what this assesses for, it's not extremely diagnostic, but we see it happen. So what you can do is, if you have something draining from a person's nose, you think it might be CSF, you have something draining from their ear, it might be CSF, you can place it on a piece of gauze. And then if there is CSF in it, the CSF will separate from any blood that's in it, and it will create a halo around that blood. Usually this test is done inadvertently for us because it just gets on the pillowcase, and you look at it, and just know that the halo side is positive if that cerebral spinal fluid separates from that blood and creates a halo around it. So with this one, you might want to say, well, we don't know if CSF is in that. Put a couple drops on the sheet or some rolls and see if it is. It's just me. So with all these head injuries, head bleeds, increased ICP, the patient is at risk for entering a state of coma. And coma is simply a definition of the Glasgow Coma Scale of less than 8. The patient can have a milder form of coma, or they can have what we call a deep coma. So it's a damage to the brain is the cause of the coma state. And during the coma state, there is changes to the RAS, the reticular activating system. Remember, that controls our sleep-wake cycle. So, therefore, the patient will not rouse. There's also what we call a Rancho's plus Amigos scale, and this measures the severity of coma. That's just an FYI. Don't go learn the Rancho's plus Amigos. Okay. We talked about how when the patient has acute increased intracranial pressure, we want to provide an environment that is not stimulating, that keeps them nice and calm and quiet, and not moving and rising and down, because we're trying to prevent secondary head injuries. But after the patient's acute phase has passed, we do want them to be stimulated, especially if they are in a state of coma. because this has shown to actually improve outcomes. It kind of wakes them up. A persistent vegetative state is different than a coma. Some people call this a coma vigil or an irreversible coma, but it's different because in a persistent vegetative state, the patient will wake up. But the key is they are not responsive to the environment. They don't follow. They might track you in the room, but that's about the only interaction they receive. So they look awake, but they will not interact with you. So if you go to try to feed them, they're not going to open their mouth. They're not going to respond to pain appropriately. So this person doesn't properly interact with the environment. That's the key with persistent vegetative state. They look awake, and they just spontaneously wake up and go to sleep. Their sleep cycle is also is altered. They might sleep all day or all night or whatever, but this person will require lots and lots of care. Does that make sense? So lower brainstem functions and the brainstem is intact. So they breathe, the heart beats, they look around and things, but the cerebrum, where you cognate, is not there. Okay.
So back in the DAI, you said severe DAI would be basically the same as yes.
A person with moderate to severe DAI will have a period of coma probably, and likely will progress to a persistent vegetative state. Does that answer your question? The thing about brain injuries and brain bleeds is that there are absolutely no always or nevers. I would heal very differently from a head bleed than Vivian would. Everybody is very different. The nice thing is that when you have very young people that have brain injuries, teenagers, children, their brain heals really fast and really well. But as we get older, our brains do not heal nearly as well as they do. So if there's a period in your life where you want to have a brain injury, it's the best time to have it because you have a higher chance of healing. Older people have a very low chance of normally healing. I worked with a nurse, and I think she was in her early 20s, and she had an MBA, and she had a brain injury and was in the ICU at the med for a long time. And she said that even to this day, her sister says that she's not the same person. She feels like she's the same, but she said that her personality is different. She's a really good person. She will soon be a CRNA. All right.
Mr. Sanford, this is a little off, right? Is there a law or anything, is there a U.S. law that when a person has to be taken off like the list or all that kind of thing? I know it's controversial, but is there any...
Yeah, it is a little bit off topic, and we'll talk more about it, but there, I don't know if there's specific laws, but there are standards of practice and standards of care. If a person is brain dead, the hospital does not have to keep them in the hospital because they're dead. So we don't take care of dead people unless we're going to take their organs. So it's inhuman, it's unethical to maintain a body that's the brain's dead. So, but it's the hospital, right? It's the hospital's decision. But there have been some things in the news recently about, like the girl that went in for a TNA, and she came out brain dead in the OR. And the family, why shouldn't that family be so upset? Because they killed her daughter. It is a risk. Anytime you go under anesthesia, you have a risk of very big injury. That's why I never want to have surgery. I never want to be intubated. I never want to. I've seen it all. I never want to have an endoscopy. I've seen it all. So, which I actually need. But yeah. So there's lots of risks. Sometimes that nurses don't do informed consent. We enforce the providers that do these procedures are really negligent in describing the risks that are involved with things that seem so routine and simple. Even with the blood transfusion, there are risks. You have a very, very small risk of contracting HIV still. But it's 99.999% sure that you're not going to get HIV from breast transfusion, but there is a chance. We can't say never always. So, but people are not really consenting. That's a big problem because, you know, if I had a child and their tonsils were big, I'd say so what. You know, they don't have sleep apnea because of it. So that's a major surgery. Just like I had a kid in the clinic. I don't know so what's that. But I had a kid in the clinic the other day, and he was 16 years old, and now he decides he wants to have a circumcision. I said, wow, what? No. He's like, blah, blah, blah. I said, do you realize that you have to go under general anesthesia and be intubated, sedated, risk of this and that? He was like, it's a simple snip, you know. So, you know, it is when you're a baby. But
I think you want that general anesthesia at this point.
I think I talked about it. But he's going to go to Cleveland Neurology. But yeah, so anyway, so there are risks with these things. And why shouldn't that mother have been upset when they killed her daughter? But I think that she's now able to find out, right? She's still alive?
I thought they moved her to a protected facility facility to take her.
Well, and she's going to rely on it because you can't, your pituitary doesn't work in your brain. They have to give you IV thyroid. So
Yeah, she's hooked up with all that.
now they're just wrong. They should have been upset at first, but now it's terrible. Anyway, let's get TIA. TIA stands for Transient Ischemic Attack. You are probably very familiar with what a CVA or stroke or brain attack is. And you've had several patients with that. But at TIA, we nickname this a mini stroke. So what happens with this is that the patient actually has a little stroke. And if a clot or something passes and it gets lodged in a vessel somewhere, and the patient has a neurological deficit. So with the TIA, that clot goes on through, and that function is restored. So the rule is basically the person has had a neurological deficit for less than 24 hours. So if you have left-sided weakness, vision changes, and it only lasts for about 12 hours, they're going to call that a TIA. Your CT scan is going to be normal, and they'll call that a TIA. But because this really is a mini stroke, this patient is at very, very high risk for having an actual stroke. So this patient will be put on anticoagulation post-TIA to hopefully prevent a stroke in the future. You're going to have, these are all manifestations of a CVA, so you will have very similar manifestations. So, double vision, difficulty speaking, things like that, difficulty walking, weakness on one side, things like that, drooping on the face. So the TIA, like I said, the manifestations pass within 24 hours, but the key with this is to prevent an actual stroke from happening. So this patient will be placed on some sort of anticoagulation. When we talked in cardiac about AFib, I mentioned Coumadin, but I didn't talk about it a lot, so I'm going to talk about it a lot now. I think that you are pretty familiar with warfarin Coumadin. First thing I want to talk about is how it works. Well, it works in the Claudine cascade, yada yada, prevents, right? That's not true. But it works and it affects what lab? INR. PT INR. Does not affect PTT. PTT goes to heparin, right? So we make PTT, 2T, make an H, right? So INR is warfarin. You have to be careful when you talk about Coumadin and warfarin. And if the patient is on Coumadin, it's Coumadin. If they're on warfarin, it's warfarin. Molecularly, it's the same thing, but they have what we call, in general, when you have a medication that's generic and trade name, they have what we call different bioavailability. So that means that usually the trade name is more pure, and you're going to get a more accurate dose. And the generic medications generally have more filler, and it's not as precise. With most medications, this is not a big deal. It doesn't make much difference at all. Cholesterol medications, blood pressure, most medications, it doesn't matter if you take generic or trade. But with medications like warfarin, doesn't necessarily matter which one you take. The thing is that the patient cannot switch from one to the other. And this should not happen because of the difference in bioavailability. Not that this medication has a higher or a bigger difference in bioavailability. It means that the INR therapeutic is very narrow. So any minute change in the dosing can throw the patient from subtherapeutic or up to supertherapeutic. So risk of clotting or risk of bleeding. Because an INR for a person who is anticoagulation is about 2 to 3. When you've been researching your patients, I know that it's happened. You go and you look up the patient's INR, and it's 1. Like, oh, it's low. No. A normal INR is 1, right? A ratio is comparison of two numbers, right? So 1 to 1 is a perfect ratio. It's comparing it to a normal PT. So in your patients, if your patients have an INR that's about 1, it's normal. Don't research it, okay? But if their INR is 0.7, 0.8, that's low. But if their INR, is 2.4, that's high. But just remember, the normal INR is 1. Right? So therefore, why you are seeing in the hospital is the normal range 2 to 3, because really the only time you monitor INR is if they're on anticoagulation. So a person who is properly anticoagulated with warfarin Coumadin will have an INR of about 2. Right? Does that make sense? And because of the narrow therapeutic range there, it's that 2 to 3, any small change in your dosing can throw you out of the normal. And that's the concept of bioavailability. All right? Hopefully you got that. Another medication that is very important to is Cerebral. We'll talk about that when we talk about thyroid disorders. All right, so the patient will be on some sort of anticoagulation. The prescriber will decide what the patient will be placed on based on their risk. So maybe low dose aspirin is enough for some people. Maybe some other people need 325 aspirin. Other people actually need to be put on warfarin or Lovenox. But remember that Lovenox and heparin are more treatment medications. More preventative medications are like Transient, Lattice, and aspirin. Warfarin. Heparin and Lovenox do not do what? Break up a clot. They prevent it from getting bigger, and the body can naturally resolve it over time. Lifestyle changes, so to prevent a CVA, you would teach the patient basically it's a cardiac diet. Like, you don't need to go to fried, fatty stuff. Keep your glucose under control, because high glucose is a huge risk factor for TIA and CVA. Medication management specifically concerning warfarin and Coumadin is what you need to be aware of. CVA has lots of names. I like the term CVA, but the newest the trend or fad now is called a brain attack. And I think this is okay because it's very similar. Basically, what's happening in the brain is what happens in the heart is a heart attack. So I think it's comparing those two things. But so on boards, on HESI, you might see the term brain attack. This means stroke or CVA. It's all the same thing. Just like the renal failure or acute renal failure is now acute kidney injury. I would say just pick something. Let's just keep changing that. So it's okay. This is a big cause of death in the United States because the United States is full of cardiovascular problems. And as a person gets older, they have an increased risk for CVA because of the risk factors, cholesterol and things like that. It works over time, the arteriosclerosis and all of those things. So all these cardiac things, really, AFib, we know why the patient is at risk for that because there's a risk of throwing clots from the atrium. There's AFib. Diabetes, this has to do with the inflammatory effects of that high blood glucose and the changes to the blood vessels because of that chronic high blood glucose. This is hyperlipidemia, HLD. I made up that abbreviation. And we talked about sleep apnea. We talked about smoking and how smoking causes vasoconstriction, and also it changes the morphology of the vessels and makes them more stiff. Hypertension, sickle cell. Remember, the sickle cell person is at risk for CB because of that, because those sickle cells not through those small capillaries. TIA we mentioned, and also this is a disease that follows families. I'm of the school that, some things are genetic, but I keep that really small. Not everything is genetic. I think that we blame genetics, and it's kind of a scapegoat. This stuff happens because we eat bad, and we don't move around. That's why this happens. That's not genetics. Being overweight like me is not genetic. Everybody in my family is saying I'm just lazy. It's just the way it's not genetic. It's that I would like to say that these things are familiar. They follow families because we teach our family members how to eat and how to act. So, there's my soapbox.
Why do people who get chemotherapy get strokes?
I am not aware of that. Really. Did I put that on there?
No. I'm asking.
Probably the changes that happen, is it a hemorrhagic or a ischemic stroke? I would think it might be hemorrhagic. Just guessing. Just guessing, I would think that it probably changes the vessel walls. Maybe makes the vessel walls thinner so the walls will be. I don't know, but that's my experience. Sounds good. Let's see, anyone who was on oral contraceptives or hormone replacement therapy, HRT, so increase in hormones and risk for really any time of life, especially if that person is a smoker. As you know, along with pregnancy comes what? Lots of increased blood volume. So this person is tension and all this. And again, people of color, especially black people in the United States, are at higher risk for stroke. I'm but part of this is genetic, and part of this is familiar. So, yeah. As you know, there's two types of strokes, right? Hopefully you knew that. If you don't, now you do. There's two types of strokes. There is an ischemic stroke and a hemorrhagic stroke. An ischemic stroke is the one that we kind of relate to, look at it compared to an MI. Because in an MI, it gets blocked, right? So for some reason, cerebral blood flow is interrupted. A stroke could happen deep within the brain, or a stroke could happen just by one of the branches of the carotid artery becoming blocked. And that's really not good because you're blocking lots of blood flow to the brain. So you could have a carotid stroke, or you could have a stroke that is deeper within the brain. But for some reason, somehow, the blood flow through that artery becomes, remember, it is an artery that becomes clogged. And therefore, that area of the brain does not get perfusion. If you don't have perfusion, you don't get oxygen. If you don't get oxygen, you get ischemia. So therefore, this person strokes as the brain tissue becomes ischemic. You learned in mental health about neurotransmitters. Glutamine is a neurotransmitter, and we need it, very small amounts. But when brain tissue is damaged, glutamate is released, and the glutamate actually causes damage to the brain tissue. Glutamate is neurotoxic. We need it in very small amounts for neurotransmission, but we don't want a lot of it. But it is released and is neurotoxic during a CVA. All right, hemorrhagic stroke. So hemorrhagic stroke is where you have rupture of a cerebral artery. The biggest risk factor for a hemorrhagic stroke is uncontrolled hypertension. The vessels are very resilient, but after 60 years of those cerebral arteries being pounded by a blood pressure of 180 or 200, this person's going to eventually stroke out. Those vessels just can't take it anymore. And they get thin and they will rupture usually because of high blood pressure. We talked about the subarachnoid hemorrhage, right? So this is often we'll see that blood in the CSF in a person who has had a hemorrhagic stroke. And what is happening here is kind of twofold. In an ischemic stroke, it's just the blood's not getting to where it needs to go because the vessel is blocked. But also in a hemorrhagic stroke, this happens because of the pressure that happens around the area. It compresses the surrounding artery, so that therefore kind of a secondary ischemic stroke happens because of the pressure on the surrounding cerebral arteries. And if the artery is bleeding out into the brain tissue or the arachnoid space, subarachnoid space, it's not getting to the tissue to where it needs to go in those capillaries to release that oxygen. Does that make sense? And again, we will have ischemia and infarction of the brain tissue, and we will have these neurological deficits. Both strokes are at increased risk for increased ICP, but specifically hemorrhagic stroke, and of course both could be deadly. One of the hallmark symptoms, and this I've seen this question on so many nursing tests, and it is, what is one of your major classic worrying symptoms of a patient who has chronic hypertension? It's a headache. And they say, this is the worst headache I've ever had in my entire life. If somebody ever says that to you, they become a level 1 in triage and they go straight to CT. Okay? This person is not ignored. It's an old person, they've had hypertension, they take Crestor, cholesterol, they take metformin for their diabetes, and they come in and they're like, oh my God, I've got the worst headache I've ever had in my whole life. Take that extremely seriously, because this could be a hemorrhagic stroke. Okay? You will see that question somewhere on SC board or something, I guarantee. I've seen it at least 5 times in all the tests I've taken. So, CVA. I'm not sure. I think maybe I updated this. This is probably 5th edition, page 1450, but there's a box in there about manifestations of CVA. But it really depends on the area of the brain that is affected. Is it the language center or what? So, realize that often these symptoms come on quickly. They are focal, meaning that it is focused on an area of the body, and it is often just one side, because the stroke is usually not going to happen on both sides of the brain at the same time. It's going to be one or the other. And usually if you have, we talked about how if the right side of the head is affected, sometimes we will see above the neck, right side, it changes specifically in the pupils, but eventually it will shift over to the opposite side. And if you have a right-sided stroke, you'll have left-sided pupils. It's the opposite. When you see the word hemi, that means half, like a hemisphere. We're in the western hemisphere, the western half of the earth, right? Go in, I'm not born yet. And so realize that anytime you see hemi, that means half. So hemianopia is loss of the visual field in either one or both eyes. So the patient can only see on the left side. They have to turn to see the right side. Agnosia is inability to identify objects. All right, now I'm just reading the slide to you. I don't want to do that. Apraxia is where a person has the cognitive ability to say, I want to pick up this cup, but they don't have the motor coordination to do so. So part of their brain has been affected that controls motor movement. They can think it's like, I want to pick that up and drink it, but they can't make their arm do it. Does that make sense? Unilateral neglect. This is kind of a syndrome and something that we don't fully understand, but unilateral neglect mostly is that when a person has a CVA, they may go into acute denial. And it's not because they're not doing it purposefully. It's part of an effect of the stroke, and they will ignore that side as if it doesn't exist. I shouldn't have put this under unilateral neglect, but another thing that happens during a stroke that is kind of interesting, and I think that can't be explained, is that the person sometimes will simply deny that it's happening. denial. And they're, again, not doing it on purpose. But they will try to tell you, I'm fine. What do you mean? Half of my body's not moving. I'm fine. What do you mean? You know, they can't cognate and realize this is happening, probably just because of the effects of the stroke. And I experienced this. My grandmother, about 10 years ago, had a stroke, and she was sitting in the kitchen. It's kind of funny now, but she was sitting there, and like the left side is hanging. And I'm like, grandmother, we have to take you to the hospital. Why? I'm fine. Idiots, what is wrong with you? The left side of your body is not moving. You know, so she did go to the hospital, but we met her. So, but it's really strange. It's very unique how that happens. There's different types of aphasia, and this is surrounding language. So expressive means that the person inside of their mind is able to figure out what they want to say, but they can't express it. They can't say it. So therefore, the part of the brain that controls expression of word is affected. Receptive aphasia means that the person can hear the words that you are saying, but it sounds like a different language. They have no idea. You're just making noise. They can't receive it. It's receptive aphasia. Usually, it's a combination of both of these if the patient has it. So some things they can understand, some things they don't. They can say some things, can't say other things. Dysarthria is not that they can't receive or express because of that part of the brain being affected, but this means that they can't move their mouth and tongue to make the words happen. If they can do that, they can do it. So it's a different part of the brain that is affected that causes dysarthria. Hemiplegia, hemiparesis. Hemiplegia is paralysis, and hemiparesis is weakness. Know the difference, weakness versus paralysis. Paralysis means that it doesn't move. Weakness is weakness. Flaccidity means that there is no muscle tone, and spasticity means there is lots of muscle tone. This spasticity puts the patient at risk for contractures. And also this person is at risk for urinary retention, lots of urinary problems. Okay? Frequency, urgency, all of those things. Constipation as well. All right. These manifestations just go on and on, don't they? Yes, ma'am.
Why would spasticity lead to contraction?
Because that's really what a contracture is tension of that muscle. That's spasticity. It's constant flexion. Again, these are more general neurological manifestations of a CBA. You know how to do a very good neuro exam. We do have we have the Ranchos Los Amigos scale, but we also have the NIH stroke scale, and it assesses these things. And we've talked about all these things. So that's just a measurement of the patient's risk of or actual stroke. But if the patient comes in and has signs and symptoms of a stroke, the first thing that you are going to do for that patient is get them to CT. So the physician is going to write an order set, and CT is going to be written stat. Get them to CT now. Realize that when the patient's stroke is ischemic, the CT will look normal. It will initially look normal. After a while, after the tissue actually becomes fully ischemic and infarcts, you will see that dead tissue on the CT scan, but not acutely. But acutely, you will see bleeding on a CT if it's hemorrhagic. And it's important to get this done quickly because we need to figure out if it's hemorrhagic or if it's ischemic. Because ischemic can be treated with medication to help reverse it. And if you give those medications to a person who has hemorrhagic stroke, it will make it worse. I mentioned how the subarachnoid hemorrhage, right, which is usually the hemorrhagic stroke, you would have blood in the CSF, right? I talked about warfarin, and these are medications that act specifically on platelets. Remember that aspirin works by affecting or inhibiting COX-1 and COX-2. That's cyclooxygenase. That has to do with the inflammatory cascade. But remember that COX-1 also has to do with the integrity of the gastric lining. So if you give a person a medication that inhibits COX-1, you put them in increased risk for gastric ulcer. That's why. Okay? Because COX-1 also is involved with the protection of the gastric mucosa. Of course, risk for bleeding. And that COX-1, COX-2 thing goes for most NSAIDs. Plavix is an antiplatelet. This doesn't decrease the amount of platelets that we have. It simply makes them more ineffective. So it prevents the platelets from sticking together. It makes the platelets slippery, if that makes sense. Yes, ma'am. It really doesn't matter if it's taken PO or not. They have these safety coded. People, I think, take those because it makes it feel better. But this happens because of the inhibition of COX-1. It doesn't matter how it's given, it's still going to inhibit COX-1. It may decrease a little pain if the ulcer is already there, if the safety code are given regularly, but if there already is a GI ulcer. Does that make sense? And of course, aspirin also acts on platelets. So the medication for an acute stroke, if it is an ischemic stroke, we can give medications that we call fibrinolytics, and these are called, we give them the nickname clot busters. This is not heparin, this is not Botox. This is TPA or streptokinase. So these medications actually help to dissolve the clot. Of course, it's only used for an ischemic stroke. This is why we have to get this CT done as soon as possible. We want to give it within, hopefully, 4 hours of the onset of symptoms, because if we get within that window, we have a good chance of restoring neurological function. Of course, this medication would put the patient at high risk for bleeding elsewhere. So that's the biggest manifestation or side effect, complication of fibrinolytics is bleeding. We would also start the patient on anticoagulants like heparin, IV heparin, and this inhibits prothrombin, right? And it prevents the further formation of the thrombus. Remember, heparin is not a fibrinolytic. Heparin is an anticoagulant. So it does not dissolve the clot. It prevents the clot from getting worse, and then maybe the fibrinolytic is also given and it will break it up, or the body will eventually break that clot down. Again, PTT is measured with heparin. PTT and APTT are a little bit different, but you don't have to know the difference. A person that is receiving IV heparin will have their PTT checked less frequently than Q6 hours until they are therapeutic. The physician or prescriber will order this based on a hospital protocol, and you, as the nurse, will adjust the rate of the heparin infusion based on what their PTT is. If the patient's PTT comes back therapeutic continuously, you're not going to make any changes. So just realize that you will have a protocol and a standard dosing for your heparin drips. I want you to go back to your dosages class, look at your dosages book, and know how to convert between heparin units per hour and heparin milliliters per hour. So if I were to say this patient is receiving 1,000 units per hour, I want you to be able to tell me how many milliliters per hour they're taking based on the concentration of the heparin. So go to your dosages book. And just set it up with ratio proportions. Okay. Just be able to do that. So if I tell you the patient's getting 900 units per hour, the concentration is this, how many milliliters per hour? It's ratio proportions. 1 second. Okay. Go back and review that. I know all of you that I taught found that dosages too. I taught you all of that. But I probably didn't have all of them. For sure. So, of course, the patient is at risk for bleeding, and heparin can cause thrombocytopenia. This is not the therapeutic or mechanism of action of heparin. Heparin, once we're working on thrombin, it inhibits it. But this can happen. It's heparin-induced thrombocytopenia. So this person actually, with this, initially becomes an increased risk for clotting because it's kind of like DIC in that all of the factors are used up quickly. The patient clots, then bleeds. So with heparin-induced thrombocytopenia, we closely measure the platelet level. At least once per day it'll be measured. And if we see a decline in it, we should report that because the patient might have heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia can happen after just one dose of heparin. You're in the hospital, you got subacute heparin one time, you have a risk for heparin-induced thrombocytopenia. It's kind of an autoimmune type of thing. They try to explain it like. Lovenox is another anticoagulant. Lovenox is easier to give and monitor than IV heparin. Often we will use IV heparin though, but Lovenox is a low molecular weight heparin and it is dosed based on body weight. It works a little bit differently and it works on factor 10A. It works at a different place in the clotting cascade. It works right at, I'll remember that, at the Y. So, but just remember that it works at a different area on the clotting cascade. So therefore, we do not monitor PTT with Lovenox. We don't normally monitor any labs, but if we want to, we can draw an anti-10A. Right? Usually you'll see Lovenox used for if a patient has a DVT or a PE, not usually a stroke, but it could be. And obviously it's
You can draw an
anti-10A, factor 10A. We don't draw from it. All right? But the majority of the time, you're not going to draw any labs to monitor heparin. We just give, Lovenox, we just give it. Of course, you want to monitor all these patients that are on anything that increases their risk for bleeding. And you want to make sure that you are monitoring and documenting specific things, not just saying, my goal for this patient is that they won't bleed. Well, that's not measurable, right, Michelle? So, make sure that any goals that you make for your patients are measurable with their risk for bleeding. When the patient is on warfarin Coumadin, you might have learned in the past, dark green leafy vegetables dangerous with Coumadin and warfarin. That's really untrue. The thing is that these dark green leafy vegetables have a high concentration of what? Vitamin K. Vitamin K is the antidote to warfarin. Well, when we start Limal on warfarin because she had a TIA, you're not going to tell her that she can't have her greens every day. You're going to say, don't eat any more or eat any less. Maintain your diet with the normal intake of dark green leafy vegetables. Dark green leafy vegetables are very healthy for us. So we do not want to tell someone to not eat them or limit them. We want to say, don't change your consumption of them. So don't go out over a weekend and have a spinach day. Take a normal amount. Don't change your intake of dark green leafy vegetables. Does that make sense? So if you see a question on HESI or something, I think it's on there. I think I saw it one time when I was looking at a student's screen. It says something about the diet of dark green leafy vegetables. It's not limited. The answer is commendable change. I'm glad that's what's responsible. Everybody's not. Okay. So this here is use acetaminophen if the patient needs something for pain incidentally, not aspirin because the aspirin will put them at increased risk for bleeding if they're already on, Right. More medicines. So again, anytime there's an injury to the brain, the patient is at risk for seizures. So one of the major medications that we use again is Dilan. And we talked a bit about this before and how we talked about only normal saline and it's given prophylactically, usually to prevent a seizure. And here is how it works. It increases the seizure threshold. You don't have to learn at this point a whole lot about corticosteroids. We'll focus more on that in endocrine. But just realize that we give them to decrease the inflammatory response, which can help to prevent true cerebral edema. A lot of this is being reiterated. It's still softeners. I said this on Tuesday. about how if the patient has an increased risk for ICP, a brain injury, we don't want them bearing down very hard to have a bowel movement. This person should have easy bowel movements and not increase the pressure in the head, not bearing down. That will help. Our stool softeners will help us with that. All of this is pretty general, I think, but neuro assessment is very important with the care of a patient with a CVA. The patient may have alterations in respiratory status depending on what part of the brain is affected. Vital signs go hand in hand with the neuro assessment. This patient is at increased risk for aspiration, maybe because they have dysarthria or they have swallowing due to their stroke, so we want to make sure that their positioning is appropriate, and that we never feed a patient that hasn't been cleared to be fed. So if the patient has any type of damage or changes to their speech, changes to their swallowing mechanism, they will be NPO until a speech therapist clears them to do. So don't go trying to feed the patient when they haven't been cleared by the speech therapist. Because you don't want to have your patient aspirate on it. Airway neurostatus, signs of pulmonary embolism, because if the patient is at risk for clotting in one area, they're potentially at risk for clotting in another area, depending on the exact physiology or cause of the clot. I think I've said all of this at some point. Your patient's position is important because it can help promote airway drainage of those secretions and prevention of aspiration. Head of the bed elevated is very good for these people because of the risk of aspiration. The person who has had a stroke, upon coming in to assess them, it would be kind of you to approach them from the side that is not affected, because it can actually scare them. They can't see you, they can't feel you. Touch their arm on the side, they can't feel anything until you start with this patient. But at the same time, when we are doing physical therapy assistance with this patient, we do want to approach from the unaffected side to get them to pay more attention to that side, to get them to use that side. But as the patient's eating, they will use their strong hand and things like that. But we do, when during therapy, want to stimulate the side that has been affected. But when approaching a patient, try to approach a patient from the unaffected side. Just kind of the patient is at risk for contractures because of the paralysis or paresis caused from the stroke. So we can splint the extremities, but the splinting would be done intermittently. So this patient would have splints continuously, usually with the boots on them or the splints on their hands. The occupational therapist often manages this, and they will write instructions for it to be taken off for 4 hours, on for 4 hours, maybe some years. But it's important, all right? And skin integrity is a big problem here because the patient has severely impaired mobility. The patient may have impaired nutrition, therefore they're at increased risk of skin breakdown. So very close assessment, lots of interventions that help prevent skin breakdown in these patients. One thing that is important with these patients is that we communicate properly with them. They're going to be slow to respond, maybe. They may take a long time to process what we've said to them. So lots of patients and slow communication with a person who has had a CVA. Psychological support from the family and the patient, and this person who has had a CVA will need some degree of physical rehab. And the physical therapists and occupational therapists are very good at this, and they're the ones that take charge. But we nurses spend the most time with the patients, so we will maintain and reinforce those therapies that have been prescribed by the physical therapists and occupational therapists. Just a quick blurb on that. We work closely with ETNOs, and they don't necessarily write orders. They have a plan of care in their own thing, and we are part of that. So don't be offended because a physical therapist is trying to tell you what to do. They're not writing orders for you to follow. They're saying, this is the plan of care for the patient's physical therapy. We expect you to participate. And if you don't, you'll be paid. So don't get offended and get on a high horse because I don't follow the routine orders. That's not the point. The point is, and I see it all the time. You tell me what to do. but they have to sometimes tell us those things to do because we have to go through the ship. It's too busy getting there are 25 pages from all of it, right? So, anyhow, there's that on that. Nursing diagnoses I'm not going to read into. I think I've described all of them already. The impaired physical mobility, the cerebral tissue perfusion, communication, urinary elimination, constipation. All this is patients have a self-care deficit because they don't have realize that there are some things that a patient can do and there's some things that a patient can't do when they have a unilateral weakness. So things that require two hands might be difficult for that patient. Things that require only one hand, the patient may easily accomplish. So keep those things in mind. I know it's almost time to leave. And I wanted to get through spinal cord injuries, but we won't. But let me talk quickly about headaches. And then we'll watch this video. I think it's really good. Be able to differentiate between the types of headaches. Probably the most common types of headaches are tension headaches, which everyone in this classroom has had, I'm sure, and also migraines are fairly common. There are differences in manifestations with these 4 different types of headaches. The thing about a migraine that stands out to me is usually that it is one-sided, and the person who has migraines can say, my head hurts right here. They can pinpoint to where the pain is. The person who has a tension headache, it's like, it just hurts all over. It's a generalized aching pain that is the tension headache. But migraine, it's very localized. The cluster headache is also localized, but this is unique because it is around behind the eye. So cluster headache is very, very, very severe. Probably the most severe of all headaches is a cluster headache. They're not extremely common, but they are more common in men. These patients, the pain is so bad that on that side of the body there will be sweating, tearing, and just involuntary. Cervicogenic comes from a neck problem. So if you have bad posture, or if you've been driving for 20 hours, your head hasn't moved, your neck's going to be really stiff, and you're at risk for cervicogenic headache. And this is the headache that's usually in the back or the lower part of the head, close to the neck, cervical, right? Also keep in mind that these things that agitate or make a migraine worse, light, sound, smells, things like that. There are also 2 types of migraine headaches, and that is called migraine headache with aura and a migraine headache without aura. And an aura is a warning. And it's different for some people. Some people might report, I know that I'm about to have a migraine because I get this weird smell. It smells like it. Or I can hear a ringing noise. Or I see flashes of light. So that's migraine with aura. Migraine without aura, okay, this is migraine with aura. The migraine with aura is it's not. A sinus headache is not really a headache. I mean, there's pain in your head, but it's a sinus ache. That's what it is. And often a sinus ache, I'm coining that, I guess, but it's a lot of manifestations of tooth pain and maxilla. But all right. So that's headaches. We'll talk about spinal cord injuries next time. We'll get through all of that, and that's a lot, isn't it? And then we'll also go through Parkinson's and ALS. Parkinson's and ALS are pretty boring. I'll get through them pretty quickly. So we'll get through all that. But I want you to watch this video. Don't go anywhere. Someone has requested that I go ahead and post the lecture from last semester on the 3rd Neuro, and I'll go ahead and do that so that if you want to listen to it to get prepared. But of course, we'll record it anyway, and I will delete the old one and leave the new one up after we have that lecture. So if you needed to prepare, I know that the test is 2 days after that 3rd lecture, but you should already be reading spinal cord injuries, right? Please read ahead.